Hi there, are you studying for your exams? Are you stressed out? Take a short break and enjoy a few seconds of mindfulness. Take a deep breath and exhale. Congratulations, you just completed an effective alveolar ventilation. Remember, calculating minute ventilation alone is not enough to ensure effective gas exchange. Patients with correct ventilator settings with adequate ventilation can still retain carbon dioxide. Why is that so? Only the air that reaches the alveoli undergoes gas exchange. The rest is dead space. Understanding dead space is key to understanding ventilation. This is mastering anesthesia. So, let's go.
So, what is dead space? It is the volume of inspired air that plays no role in gaseous exchange. We write it as VD. And that includes the air remaining inside, number one, the conducting airways, and number two, the non-perfused alveoli. You can see the markings on the left where this is the airways and the non-perfused alveoli where carbon dioxide and oxygen exchange does not occur. On the other hand, alveolar volume, written as VA, is the volume of air which reaches the perfused alveoli. Think of alveolar volume as the complete opposite of dead space. The diagram shows the portion of alveolar volume where the air eventually reaches the alveoli which is perfused, so carbon dioxide and oxygen exchange can occur. Therefore, our normal inspired breathing or tidal volume is equal to the sum of alveolar volume and dead space. This is a very important concept, so get it engraved in your head that every time we breathe, we are actually breathing both alveolar volume and dead space that occupies our lungs and airways. Getting to know more about dead space, there are actually three types of dead space. We have the anatomical dead space, the alveolar dead space, and the physiological dead space. The anatomical dead space, written as such, is the volume of the upper airway and the first 16 generations of the tracheobronchial tree. Therefore, the name suggests that it is purely anatomical. It involves the airway and only the 16 generations of tracheobronchial tree. Number two, alveolar dead space. Alveoli being the keyword here is the volume of ventilated alveoli that are unable to undergo gaseous exchange. So air reaches the alveoli, but no gas exchange occurs because it is insufficiently perfused. Example are VQ mismatch. Lastly, physiological dead space is basically the total dead space, meaning that is the sum of the anatomical and alveolar dead space, written mathematically as such. Physiological dead space is equal to anatomical dead space plus alveolar dead space. We've been talking about volumes and dead space, but how are they actually measured? We use different methods to measure different dead spaces. So for anatomical dead space, we use Fowler's method, which is a single breath nitrogen washout. It can be used to calculate anatomical dead space as well as closing capacity. Remember that anatomical dead space is approximately about 2 mils per kilogram body weight. So for a 70 kilogram man, anatomical dead space would go about 114-150 mils. Physiological dead space does not use the same method. It uses the Bohr method, using Bohr equation to calculate the ratio of physiological dead space to tidal volume. Normal physiological dead space is about 0.2 to 0.35 ratio of physiological dead space to tidal volume. Now let's talk about factors that increases or decreases dead space. But before that, a few key figures for us to be accustomed with. Normal tidal volume for a 70 kilogram man is about 150 mils, which is approximately 2 mils per kilo, which is also about 1/3 of tidal volume. If we take about 6 to 8 mils per kilogram body weight, so dead space is 1/3 of that. There are 5 main reasons of factors affecting dead space. Number one, size of the patient. So bigger patient has bigger lungs, therefore they have a bigger anatomical dead space. Number two, lung volume. At an increased lung volume, let's say a patient breathes in and holds his breath. This is a condition where the lung is at an expanded state. So what happens is that the airways will be pulled by radial traction. So when the airway diameter dilates, there will be increased in anatomical dead space. So let's see from the diagram. You have here two lungs, trachea, bronchial tree, and as well as the diaphragm. So when the person inhales, the airways and the lungs will expand. So the diameter will also expand. So when the airways expand, the volume is increased. Therefore, this portion of the air is not involved in the gases exchange. So immediately this becomes the dead space. Number three, posture. So let's take a person who's lying supine. So when they're lying supine, the lung volumes decreases. The chest wall will collapse. The abdominal muscles, abdominal contents will go up. So the airway diameter will reduce, and this will effectively reduce the anatomical dead space. Number four, bronchoconstriction. So what happens when the airway becomes constricted? The airway diameter reduces, so by default, the anatomical dead space will also reduce. And contrastingly, bronchodilation, so airway diameters will expand, so this will cause the anatomical dead space to also increase. So far, we've talked about physiological dead space as well as anatomical dead space and how we measure them. But what about alveolar dead space? Alveolar dead space cannot be measured directly. However, we can derive its value by knowing the other volume of physiological dead space and anatomical dead space, and by mathematical equation, we can get the value of alveolar dead space. So if you remember earlier, you can get the value of physiological dead space by using the Bohr method and using the Fowler's method to get the anatomical dead space volume. By using simple mathematical equation, the alveolar dead space can be calculated. Alveolar dead space are not usually mentioned because in normal lungs, the ventilation and perfusion are well matched. So therefore, there is no rule to calculate alveolar dead space because it is not present. Even so, we have to acknowledge that there are factors that increase alveolar dead space. Number one, being in an upright posture. So what happens, blood will pull down in the base of the lungs due to gravity. So only a bit of blood only just perfuses the apices. So this causes the apex to be well ventilated, but have poor perfusion for gas exchange. So there will be VQ mismatch and also increase in alveolar dead space. Number two is low pulmonary artery pressure. This can happen due to right ventricular heart failure, which causes the reduce in ventricular output to the lungs, meaning less blood will be perfusing the lungs, causing VQ mismatch and increase in alveolar dead space. Next, number three is by the introduction of PEEP, positive and expiratory pressure, and also PPV, positive pressure ventilation. So how did this come about? So when you give PEEP to the lungs of the patient, you're increasing the alveolar pressure. This pressure will compress the nearby capillaries, making the alveoli, well, less perfused, especially true in the apices. Another thing that will happen here is by introducing PEEP and PPV, there will be a resulting increase in intrathoracic pressure. Of course, this will reduce venous return, causing reduce in right ventricular output. This will cause reduced perfusion to the lungs, increasing VQ mismatch, and increasing alveolar dead space. Number four, the obstruction of pulmonary arteries. Now, pulmonary artery can be obstructed by a few things. It can be from thrombus, from gas, from fat, and also from amniotic fluid. So this will result in the alveoli downstream to the artery will get only ventilation but no perfusion because blood cannot flow there, therefore increasing alveolar dead space. Next, number five is chronic obstructive pulmonary disease. In COPD, the pathology will include the destruction of alveolar septa. So instead of two functioning alveoli, the septa will be destroyed, meaning there will be only one functioning alveoli. Let's take that for example. Yeah. So in total, it will result in a reduced surface area available in the alveoli for gas exchange and result in increase in alveolar dead space. Now that we're done talking about dead space, Let's now talk about ventilation. This is a very important core concept in anesthesiology, so let's go. So, ventilation, understand that it is the movement of air in and out of the lungs. There are different types of ventilation. We're going to go through it one by one. The first one is minute ventilation. It is the volume of air inspired in 1 minute. It can be written as capital V with a dot on top. E is equal to tidal volume times respiratory rate. We're using E here, E for exhalation, because it's the exhaled gas that can be measured. A few footnotes that I like to highlight so that our audience will be clear. The V, capital V with a dot on top, means volume per unit time. It's not just volume. The capital V means volume in milliliters. The E in VE is expired gas, because inspired is almost approximate to expired, and measurements are usually always done using the gas exhaled. The next type of ventilation, which is the more important ventilation, is alveolar ventilation. It is the proportion of minute ventilation that actually takes part in gas exchange. This portion of ventilation is the one that contributes to oxygen moving into the blood and carbon dioxide diffusing out of the blood. It can be written mathematically as alveolar ventilation is equal to alveolar volume times with respiratory rate. And if you remember, the formula for alveolar volume is tidal volume minus what is not necessary, which is the dead space, and times this with respiratory rate, and you get alveolar ventilation. The contrasting opposite of alveolar ventilation is dead space ventilation. This is the proportion of minute ventilation that doesn't take part in gas exchange. Mathematically, it can be written as dead space ventilation is equal to dead space volume times with respiratory rate. So you can get the volume of dead space by minusing tidal volume with alveolar volume times this with respiratory rate, and you'll get dead space ventilation. So if you take a step back and see ventilation in a bigger picture, you can see that minute ventilation is actually the sum of both alveolar ventilation and dead space ventilation. So knowing this, you will understand that minute ventilation alone is not enough for gas exchange. You have to take into account dead space ventilation as well as minute ventilation, alveolar ventilation that actually contributes to oxygen and carbon dioxide gas exchange. I'd like to elaborate on this further by bringing our attention to dead space ventilation. It is basically the movement of air in the airways. It's just moving in and out without actually contributing to gas exchange. Let's try and illustrate this. We have the trachea, bronchi, lungs, and these are the gases, and these are the alveoli. So if you focus more on achieving only minute ventilation and not paying attention at all to alveolar ventilation, for example, you're increasing the rate but low tidal volume, look at the movement of gas. You're just oscillating the gas in and out of the trachea and bronchus without actually reaching the alveolus, which is where alveolar ventilation actually occurs. So no alveolar ventilation, meaning no gas exchange. So we've seen how alveolar ventilation affects carbon dioxide and oxygen level. So graphically, how does this relation look? The relationship between alveolar ventilation and an arterial carbon dioxide tension is based on PaCO₂ equation. It can be written as PaCO₂ is equal to K times VCO2 divided by alveolar ventilation. VCO2 here stands for the rate of carbon dioxide production in the body per unit time. K here stands for the correction factor, because both VCO2 and VA uses different units. VCO2 uses mils per minute, and alveolar ventilation uses liters per minute. So the correction factor unifies this into a single unit. So if the unit that we're interested in for PaCO₂ is kilopascal, the correction factor K is 0.015. So notice the inverse mathematical relationship between PaCO₂ and alveolar ventilation. As alveolar ventilation increases, there will be a resultant reduction in PaCO₂. Doubling the alveolar ventilation will result in halving of the PaCO₂. Now let's see this in a graph. Shown here is a graph of PaCO₂ against alveolar ventilation. It shows the inverse relativity between PaCO₂ and alveolar ventilation. The lower the alveolar ventilation, the higher the PaCO₂, and the higher the alveolar ventilation, say 14 liters per minute, the lower the PaCO₂ in kilopascal. So when we say doubling the alveolar ventilation results in halving the value of PaCO₂, let's take for example, we have a alveolar ventilation of 4 liters per minute, we have a PaCO₂ level of 5 kilopascals. Now let's double our alveolar ventilation to 8 liters per minute. We can see the PaCO₂ level here, if you trace carefully, it is at 2.5 kilopascal. So the value have halved just because we have doubled the alveolar ventilation. In another scenario, in a ventilated patient, say the metabolic rate of the patient increases, meaning that the rate of CO2 production per unit time increase, such as in sepsis or malignant hypothermia, but there are no compensatory mechanism by the alveolar ventilation. Therefore, there will be a resultant increase in PaCO₂. So the takeaway message from this lengthy explanation is that alveolar ventilation determines the PaCO₂, not minute ventilation alone, which includes dead space, and we can only just ventilating dead space and not affect PaCO₂ whatsoever. Okay, last but not least, to consolidate our understanding further, I'd like to show a clinical example. We compare two different patients with the same minute ventilation, but we get the same minute ventilation with differing tidal volume and respiratory rate. Case number 1, you have a tidal volume of 500 mils, rate of 16, with a minute ventilation of 8 liters. Meanwhile, case number 2, you have a tidal volume of 250 mils, respiratory rate of 32, but both will achieve a similar minute ventilation of 8,000 mils. So in these two case scenarios, will they have the same resulting PaCO₂? Let's find out. If you take dead space volume into consideration, we can assume that case number 1 has a dead space of 150 mils and case number 2 is similar dead space of 150 mils. Now let's see. Alveolar volume is equal to tidal volume minus dead space will result in alveolar volume of 350 mils. Alveolar ventilation is alveolar volume 350 mils times with respiratory rate of 16, bringing our alveolar ventilation to 5,600 mils. Whereas in case number 2, alveolar volume is equal to 250 of the tidal volume minus with a dead space of 150 mils will result in 100 mils of alveolar volume. Therefore, alveolar ventilation is alveolar volume of 100 times with a respiratory rate of 32 will give us a 3,200 mils per minute of alveolar ventilation. This clearly shows how case number 1 has a higher alveolar volume, therefore the CO2 will be lower in case number 1 as compared to case number 2. And there you have it. Thank you so much for watching this video till this very end. Continue supporting us, like, comment, subscribe, and I'll see you on the next video.
Thank you for watching. If you find these videos helpful, please hit the like and subscribe button to show your support. Comment down below what topic you want us to cover next. Till next time, see you in the next video.